This information presented in this course is based on reference materials that are believed reliable and consistent with standards accepted at the time of presentation. Possibility of human error and ongoing research and development in medical sciences does not allow assurance that the information contained herein is in every respect accurate or complete. The information presented during the course is intended for teaching of undergraduate and graduate students in biomedical education and is intended only for teaching. Students who successfully complete this course should check the product information sheet included in the package of any drug they plan to administer or dispense to be certain that the information presented in this course is accurate and that changes have not been made in the recommended dose or in the contraindications for administration. July 9th, 2014. Lipid-lowering drugs for hyperlipidemia. The term hyperlipidemia is a general term, and it really refers to elevated serum lipids. But the term itself doesn't really tell you the cause of the increased levels. Why is there elevated lipid in the blood, and what kind of lipid? Is it cholesterol? Is it triglycerides? Is it elevated levels of a lipoprotein? What's going on? So the term hyperlipidemia, in some ways, is general, and you need to know more. By the way, a related term called hyperlipemia would refer to elevated triglycerides only. Okay, so hyperlipemia would refer to elevated triglycerides. And the reason why I mention this is clear in the next slide. As you can see, in this slide, we have an atherosclerotic plaque. Atherosclerotic plaque tends to correlate with poorly controlled plasma lipid levels, okay, or with hyperlipidemias. On the other hand, at this point, I'd like to mention that elevated triglycerides actually cause a related but a distinct phenomenon where the pancreas can become inflamed, a situation called pancreatitis. And we'll get back to that in a little while. But right now we're going to talk a little bit about atherosclerosis and the players involved in the development of this plaque. And yesterday you learned about the pathology of plaque formation, and today we're going to really be talking about these components more from an intervention stance. What is it about this this cell that can be inhibited to reduce or prevent growth of the plaque? And remember, plaques can be sites of blood clot formation, and clots are trouble. And as we heard Dr. Soretta discuss, when the endothelial layer of the lumen there becomes damaged, we can start to see coagulation of red blood cells and form a thrombus or a clot. And so this is a major area of concern. So what we're going to be talking about now is this phenomenon of dyslipidemia, which is basically a general term for elevated blood lipids, but you need to know more. What kind of elevation are we talking about? The primary hyperlipoproteinemias include disorders such as primary chylomicronemia. This is a situation where chylomicrons are increased in the blood, as are VLDL. And this disorder can be treated through dietary modifications and monotherapy with something like fibrate or omega-3 fatty acid or niacin. Recent studies have also shown efficacy for combination treatment of niacin plus fibrate. And I'm going to mention these drugs in detail in a little while, but just to introduce them here. Again, treatment of hyperlipoproteinemias, a situation where you have too much of a particular lipoprotein. So we talked about chylomicronemia, but there's also familial hypertriglyceridemia. And here we have a situation where there's elevated triglycerides. And so chylomicrons in the blood may be increased as they're a major carrier of triglycerides. VLDL in the blood may be increased. And in these situations, we can use monotherapy with similar drugs or drug combinations of niacin and fibrate. Again, a hyperlipoproteinemia is an elevation in any lipoprotein species. There's familial combined hyperlipoproteinemia, and this is a disorder where you may see VLDL increased, chylomicrons may or may not be increased, but VLDL is predominantly increased in this disorder. And again, dietary modifications may be effective, but generally in combination with monotherapy are effective. And so things like omega-3 fatty acid, fibrate, maybe an HMG-CoA reductase inhibitor. So we're going to explore these in a little more detail as we go further. Okay, but that's an example of familial combined hyperlipoproteinemia. So here you have a few lipoproteins that are out of whack. Then we have familial dis-beta lipoproteinemia, where clinical manifestations include elevations in VLDL remnants, and the chylomicron remnants may also be increased. But again, that's not typical. However, familial hypercholesterolemia, where cholesterol levels are higher than would otherwise be anticipated, have been found to exist. And we've heard about some of these already in the pathology lecture. But they basically all increase LDL levels. And so there are certain types of drugs that will be effective in this situation, which we'll talk about as we go forward this morning. Lastly, we have familial ligand defective apoprotein B, where the ligand is defective, unable to bind to its LDL receptor. And we have lipoprotein A, hyperlipoproteinemia, where lipoprotein A is increased, and that's been found to be treated with niacin. And so some of these terms seem complicated, but in fact, when you look a little more closely at them, they pretty much tell you which of the lipids or the lipoproteins are elevated here. Now, for purposes of exam, I wouldn't ask you to know all of these by heart, but those such as familial hypercholesterolemia or familial hypertriglyceridemias are more common than others. So there are some secondary causes of hyperlipoproteinemias. Ways to achieve hyperlipoproteinemia, not through genetic mutations or presence of genetic variants. And so here we have certain diseases or drugs that can cause hypertriglyceridemias. And these include things like diabetes, excessive alcohol ingestion, and in fact, several different types of agents may affect triglyceride levels, and so that's important to keep in mind if you're treating a patient with some of the drugs that are listed here. For example, estrogens or protease inhibitors. It's also known that certain conditions or drugs can increase cholesterol levels in the body. And so we've seen hypercholesterolemias in people with hypothyroidism or in people with cholestasis or corticosteroid excess. And so if you look, corticosteroid excess can result in both hypertriglyceridemia and hypercholesterolemia. This slide contains the Fredrickson classification of the hyperlipidemias. And this is a classification based on phenotype, where certain lipoproteins are elevated, resulting in various effects on serum concentrations of the various lipids. So, for example, if we look at the Fredrickson classification for the 2B phenotype, patients will present with elevated LDL and elevated VLDL. The serum cholesterol concentration will be much higher than anticipated. The serum triglyceride concentration may be much higher than anticipated. And if you look at the relative frequency of this particular phenotype, it's about 40% of the cases of hyperlipidemia can be attributed to this particular phenotype. So this is just a reference slide for us all, looking at total cholesterol in the body, with desirable being below 200 mg per deciliter, and high risk for atherosclerosis being above 240 mg per deciliter. If we look at LDL cholesterol, really desired is less than 130. These days, most people will tell you less than 100, in fact. But high risk for atherosclerosis is an LDL above 160. For HDL, we'd like to see HDL levels above 60 mg per deciliter. And below 35 mg per deciliter is generally considered high risk. Now, I'm not holding you directly to these numbers. I'll defer to the therapeutics faculty on this. But generally speaking, things haven't changed that much since this slide was prepared in 2006. And so the borderline, or what physicians consider borderline regions, may have changed. But generally, a total cholesterol of 270 is considered high risk. An LDL cholesterol of 170 would be considered high risk, or HDL of 10 would be high risk. So just to give the numbers some perspective. So the idea here is when lipid levels are high and high enough to correlate with things like atherosclerosis, or in the case of elevated triglycerides, pancreatitis, we want to lower the lipids. And we can do this through several ways. One way is through a low lipid diet and a dietary modification. As we know, it's not always easy to change the diet, but it is possible in certain instances to reduce considerably the amount of lipids that we consume if a person is consuming way above what would be considered normal. There are other ways to lower lipids, so dietary bulk, such as fiber. People who regularly take Metamucil for constipation, they tend to have lower LDL levels by about 8% lower than what would otherwise be. Bile sequestering agents can lower LDL up to 30% and include drugs like cholestyramine, cholestyramine, and colsevolam. Excuse me. We have inhibitors of hepatic synthesis of lipids, things such as niacin, the fibric acid compounds, or the statins. And then there'll be a few other compounds that we can talk about, things like Probucol or estrogens, or certain vitamins, or ezetimibe that have been found to be effective at lowering lipids. So this slide sums it up. The drugs we're going to be talking about for the remainder of the morning: the bile sequestering agents, the cholesterol absorption inhibitors, niacin, propicol, fibric acids, statins, and ezetimibe. This is a cartoon sketch of a lipoprotein. And as you can see, lipoproteins have a hydrophobic core composed of cholesterol esters in yellow circles within the core, and triglycerides depicted here by green circles within the core. So these are particles that have hydrophobic core regions containing cholesterol esters and triglycerides, and are surrounded by unesterified cholesterol, phospholipids, and apoproteins, which are depicted here on the outer portion. So we have our phospholipids, our unesterified cholesterols, and our apoproteins. Now, certain lipoproteins contain very high molecular weight B proteins. As you see in this diagram, we have a B protein called B100. Those that have B100 on their surface are synthesized in the liver and include VLDL, VLDL remnants, LDL, and lipoprotein A. So, very low density lipoproteins are converted to VLDL remnants, also known as intermediate density lipoproteins, by lipolysis via lipoprotein lipase in the vessels of peripheral tissues. This slide depicts metabolism of lipoproteins of hepatic origin. If you look at the very top portion of this slide, towards the middle left, you'll see a Golgi vesicle that's secreting, or exocytosing, I really should say, a VLDL, a very low density lipoprotein, into the blood. That very low density lipoprotein has apoprotein B100 on its surface in green. It has apoprotein E and apoprotein C, which it has acquired from HDL. It also has a green square. The green square represents apoprotein C. Alright, so if you're looking still at the top middle, you see that VLDL particle that has been released by the liver. Okay? It's got apoprotein E, it's got apoprotein C. And the green rectangle represents apoprotein C2, another type of apoprotein. Now, that VLDL particle is going to encounter lipoprotein lipase. And by the way, in the VLDL particle, we predominantly have triglyceride, as indicated by the light blue color. And so that triglyceride is going to meet lipoprotein lipase on the surface of capillary endothelial cells or the target tissues. And free fatty acids can now be absorbed into those adjacent cells. Meanwhile, the VLDL remnant has less triglyceride than it had before, will give up some of its apoproteins, particularly apoprotein C, to form a new HDL particle. Now, that VLDL remnant is going to be further acted on by lipase And so the VLDL remnant is converted to IDL by lipoprotein lipase. Now, some of the VLDL remnants are converted to LDL through further loss of triglycerides and loss of apoprotein E. A major pathway for LDL degradation involves the endocytosis of LDL by LDL receptors either in the liver or in peripheral tissues. And so you can see here that those receptors are depicted as seashells, but they are going to bind to LDL and become internalized. As you can see on the bottom left corner, we see that the hepatocyte also possesses an ability to make cholesterol de novo from acetyl-CoA. In this figure, we have various members of the low-density lipoprotein receptor gene family. As we can see, they share certain extracellular sequences, such as ligand-binding repeats and what are called EGF precursor domains. But without getting into too much detail of the structure of these various family members, if you look way to the left, you see LDL receptor. And the LDL receptor is mutated in familial hypercholesterolemia. That's what that parenthesis is telling you about. And we learned about that yesterday from Dr. S.W.Z, where we said that, certain people are unable to bring in LDL out of the blood, and so cholesterol levels stay very high. If we look at this receptor, we see that it's highly conserved from mammal to chicken to frog, and even to the shark. And the shark's a very interesting part of this story because the shark was one of the first species studied when it came time for cholesterol being discovered and how its synthesis was made known. And so the LDL receptor has certain functional motifs, which include an LDL receptor repeat in red, an EGF precursor domain in blue, and an O-linked sugar and transmembrane domain. And so this is what will bind to LDL and allow it to become internalized for endocytosis. And so whether it's the liver that needs cholesterol, whether it's target cell, for example, in the periphery, the receptor is going to look like this. This diagram represents a scheme for the scavenger receptor class B type 1 mediated cholesterol flux between HDL and cells. So unlike other cell surface receptors that bind and internalize lipoproteins for intracellular degradation and cholesterol release, scavenger receptor class B type 1 can bind HDL reversibly while still mediating cholesterol transfer between HDL particles and cells. The localization of SRB1 in plasma membrane caveolae seems to be crucial for its role in cellular cholesterol influx and efflux. When SRB1 interacts with cholesterol-rich HDL, it facilitates selective cholesterol ester uptake and reversible incorporation into the plasma membrane caveolae, from which cholesterol molecules are irreversibly internalized through an extralysosomal non-endocytic pathway for intracellular metabolism. or for storage. Alternatively, SRB1 binds cholesterol-poor HDL, stimulating the efflux of excess of cellular-free cholesterol from plasma membrane alveoli into HDL particles. SRB1 might also stimulate cholesterol efflux independently of HDL binding by changing the lipid domain composition and organization of the plasma membrane. The net flux of cholesterol will ultimately be determined by the differential concentration gradient between HDL and cells. This diagram from our textbook shows us some of the important sites of drug action that we'll be discussing today. The particular targets of interest are those indicated in this picture as white rectangles. The first of which you can see right in the middle of the hepatocyte, the HMG-CoA reductase enzyme as a target for inhibition, which therein reduces cholesterol synthesis by the hepatocyte. And as you watch where cholesterol can go, it can go directly into the gut, or it can be converted into bile acids and then be dumped into the gut, or it could be packaged into VLDLs and sent back out into the blood. So HMG-CoA reductase, very important target. If we look at some of the other targets, we see that, for example, ezetimibe will prevent cholesterol reabsorption from the gut, or the bile acid sequester major drugs resins that are therefore going to prevent reabsorption of bile hyperlipidemia are listed here on this slide. A drug like niacin, we've seen some of them already in the previous slide. The movement of cholesterol into probably by far the most common class encountered. And so really the net effect of all of these in drug management of this hyperlipidemic condition have a similar endpoint, and that is they reduce circulating levels, also known as cholesterol. They're called statins, and so if you look over to the right, you'll see some of the common types or examples of inhibitors of this enzyme. All contain that word, statin. Torvastatin, fluvastatin, pravastatin, rosuvastatin, and so on. And so these drugs are all mechanistically similar. And what is that mechanism? That mechanism is inhibiting cholesterol synthesis in the liver by blocking that enzyme HMG-CoA reductase. Interestingly, this leads to an upregulation of receptors for LDL on the surface of hepatocytes, which can help clear more LDL out of the blood as it gets internalized into the liver. So its major mechanism is that of inhibition of the HMG-CoA reductase. Its major effect is the lowering of LDL cholesterol. There's also a modest lowering of triglycerides that's been observed in patients, and a modest increase in HDL cholesterol. But by far, the lowering of LDL is its major pharmacologic effect. And some of the common, or I should say, some adverse reactions that are worthy of mention are that of elevated hepatic enzymes. So people who take these drugs are going to have to go for liver function tests regularly. Elevations in CPK, which is creatine phosphokinase, and myopathy, muscle pain, ranging from minor pain to severe muscle pain, and quite unfortunately in some patients progressing to rhabdomyolysis, or the breakdown of muscle, skeletal muscle. And of course this is something that we would like to avoid because this has severe consequences, particularly can, in addition to being toxic to muscle, can affect kidney function dramatically. Now, the second group of drugs used to treat hyperlipidemias are bile acid binding resins, or sometimes they're called the bile acid sequestering agents. And what these drugs do are that they bind to intestinal bile acids, and they keep them in the intestine, interrupting the enterohepatic recycling that would otherwise have occurred. Okay, so we're keeping the bile acids in the intestine. We're not letting it recycle back to the liver. This is going to in turn result in LDL receptor upregulation, just like what we saw with HMG-CoA reductase inhibitors. And so this pharmacologic mechanism of action leads to the lowering of LDL cholesterol. However, a very important difference with these drugs compared to statins is that these drugs actually raise triglyceride levels slightly. And so in patients that have elevated triglycerides already, that these drugs are not useful. Okay, so a triglyceride panel is really going to need to be known. A triglyceride level is really going to need to be known before initiating treatment with these drugs because of the ability of them to raise triglycerides. There are three bile acid binding resins currently available: cholestyramine, cholestyramine, and cholestyramine. And the adverse reactions associated with these drugs are generally limited to the gut and include things like gas, bloating, constipation, or cramping. Again, that's generally the most typical types of adverse reactions observed with the bile acid binding resins, but one will need to keep an eye on the triglyceride levels in the patient. Fibric acid derivatives. Now, fibric acid derivatives lower triglycerides and raise HDL, cholesterol. Okay, so these have a double effect here. We have a lowering of triglycerides and an increase in the good cholesterol, less of an effect on the LDL cholesterol, which again is the big culprit here in atherosclerosis particularly. The mechanism of action probably is due to inhibited synthesis of VLDL. And there's evidence later that we'll discuss to show that these fibric acid derivatives may be PPAR receptor agonists, and that may also help contribute to the effects we see on triglycerides and HDL. The two fibric acid derivatives currently available are fenofibrate and gemfibrozil. And the major adverse reactions that are observed with these fibric acid derivatives include things like dyspepsia, constipation, myositis, or in some cases anemia. And so blood tests will need to be done as well to monitor effects on the blood cells as the patient goes through treatment. Nicotinic acid, also known as niacin, has an ability to lower triglycerides and LDL. This is believed to occur through a mechanism that involves the upregulation of hepatic LDL receptors and the clearing of LDL, increased clearing of LDL from the blood into the liver. This drug needs to be used carefully, even though it's niacin, it's a B vitamin. Its use in hyperlipidemia is at very large doses, and in some patients there's actually a facial flushing that can develop. In some patients these high doses of niacin are toxic to the liver, and so we'll talk a little bit about this again in detail as we move forward. The cholesterol absorption inhibitors are these drugs. Right now there's one on the market called M.A.B, but there are others in development. And these drugs inhibit intestinal absorption of cholesterol and plant sterols and lower LDL cholesterol. Adverse reactions associated with the cholesterol absorption inhibitors include myopathies, although not typically severe myopathies like rhabdomyolysis. But myopathy, some muscle pain has been observed in patients taking ezetimibe, as well as some stomach upset. Remember, these are going to be keeping cholesterol in the intestine, and so this may cause, at least in the beginning phases of treatment, some alterations in typical bowel movements and such. So let's go into these drug classes in a little more detail now. So that was a basic overview of the drugs. Now let's talk a little bit about some of the things, reinforce some of those ideas, and then add a few things that are worthy of mention. And so again, the bile acid sequestering agents, or sometimes they're called the bile acid sequestering resins, are generally given orally. And again, they work in the gut. Okay, they work in the gut to retain bile acid salts in the gut, and therefore reduce the recycling of cholesterol back to the liver. These drugs are generally safe for children. There's been an absence of studies in children younger than 10 years of age. Okay, so if you're looking for a safety profile in younger children, it's unclear. Now, hopefully we're not treating people that are too young for high cholesterol, but as you've learned in pathology, there are some genetic conditions where people will have variants for certain receptors or for certain lipoproteins, and may have very high levels of cholesterol, which may actually necessitate treating them at a younger age. Okay, but generally speaking, your cholesterol goes up as you get older, and so you don't tend to see very young patients on these drugs per se, but I'll never say never. And so the three common members of this class are cholestyramine, cholestyramine, and cholecylamine. And their chemical structures are depicted for you here on the left. You'll see that there are brackets around the typical core structure. And what that basically means is that these are polymers. You'll learn more about their structure in the medicinal chemistry portion. But as you can see, they're all taken orally, either as tablets or as oral suspensions. And again, the mechanism of action here is depicted for you down here in the lower right panel, where you have a hyperlipidemic patient who's being treated with bile acid binding resins. Remember, normally cholesterol in the liver, one of its fates is to be converted into bile salts, which get dumped into the intestine and help in digestion, and are usually reabsorbed back into the circulation and brought back to the liver in this process we call enterohepatic cycling. So most of the bile acids and salts that are secreted initially are reabsorbed. However, when a resin like cholestyramine is given, that bile acid precipitates out. It forms an insoluble complex and is no longer reabsorbed. And so as that leaves, it takes cholesterol with it, right? And so the liver needs to take some of that cholesterol that it has and make more bile salts. And so we take away some of the body's burden of cholesterol by mopping up the bile acids inside the gut. And eventually this insoluble complex will pass out through the feces. Okay, so normally bile acid salts are secreted by the liver into the gut, but are reabsorbed back from the systemic circulation into the liver through this enterohepatic cycling. And the bile acid sequestering agents are going to disrupt that enterohepatic cycling and cause cholesterol to leave. And so what can we say about the bile acid binding resins? These are generally non-absorbable, large, anionic exchange resins. It binds to bile acids in the GI tract. They're highly positively charged, and they bind to negatively charged bile acids, depleting up to 95% of normally reabsorbed bile acids and forcing the liver to use and to lower blood cholesterol to make new bile acids. And so these compounds inhibit the reabsorption of bile and promote fecal elimination, which will then require the liver to synthesize new bile from cholesterol, which will occur via a hydroxylation reaction, which you'll learn more about from Dr. Corlapara. And so here we have an increase in uptake of plasma LDL to bring more cholesterol into the liver so that more cholesterol can be used to make bile acids, and so on. And there have been reports to indicate that blood LDL levels can be lowered by up to 20% with these drugs. Okay, so that's a very sizable percentage reduction. So the bile acid resins are those which will generally be used in children with hypercholesterolemia because of their lack of systemic adverse reactions. Again, safety has not been established in children under the age of 10, but in children with high cholesterol, and this will tend to be those with genetic predisposition, these bile acid binding resins are efficacious. So not only have they been found to be useful in hyperlipidemia treatment, but also they've been useful in the treatment of digoxin toxicity in patients who have symptoms of digoxin toxicity. In addition, in cholestatic situations where you have cholestasis, too much bile acids and not enough efflux, some patients will develop a condition called cholestatic pruritus, or have rash on the skin due to biliary obstruction. And so in this case as well, the bile acid binding resins have been very useful. Now the lipid lowering begins 24 to 48 hours after the start of treatment, but really may take months for levels to come down and stabilize. Alright, so this is going to be a treatment that may take days to weeks to months to see that 20% improvement. Now, for people with cholestatic pruritus, it's going to take about 1 to 3 weeks to see improvement, as opposed to people that have bile diarrhea. It's going to begin in about 24 hours. Note that there's no distribution, metabolism, or excretion. This is all GI mediated. Okay, this is not having a systemic effect. Again, some slight elevation in triglycerides has been observed, but effects on LDL lowering are very encouraging. Now, there are some important drug interactions that are worthy of mention, and these are going to be particularly those caused by changes in absorption of drug due to altered bile acids in the intestine. Recall that bile acids are important for the emulsification process during digestion, but also as drugs are dissolved and as they enter into the gut, the presence of micelles can affect or enhance or help their absorption. So now if you're giving a patient a bile acid binding resin, you may affect the absorption of certain drugs. And so there have been some documented absorption drug interactions with cholestyramine or cholestyramine or cholestyramine. And these include some big ones, interactions with things like warfarin. We talked about digoxin. It's going to help in removing digoxin from the body. In a setting of digoxin toxicity, that's good, but in a setting of digoxin efficacy, and now you're altering its levels in the body, that's not good. Tylenol, certain steroids, including corticosteroids and sex steroids, and thyroid hormone, thiazide diuretics, and beta blockers, have all been found to have absorption drug interactions with these bile acid resins. And so it's wise to separate when the patient's taking both of these drugs, when they take the drugs, so as to not take them together. We also see decreased absorption of dietary vitamin K, and we've seen in some patients consequences due to that, such as hypoprothrombonemia and bleeding. And so, generally, the anion exchange resins will tend to bind to anionic drugs, things like the NSAIDs, things like the anticoagulants, and so on. Okay, so you have absorption drug interactions due to altered, the altered conditions of the intestine itself, and then you have physical drug interactions of these positively charged resins interacting with negatively charged drugs. So hopefully that's clear. Now, cholestyramine as the prototype of this class. Some things, again, just to reiterate or reemphasize. In terms of the adverse effects, the GI effects are most pronounced. Recall that this drug is not systemically absorbed, but going to cause all kinds of GI effects. Things like constipation have been observed, or fecal impaction, or hemorrhoids, or abdominal discomfort, or gas. Steatorrhea, when taken with food, that's kind of like fatty stools, oily stools. Bloating, dyspepsia, you name it. Okay, so there have been lots of GI effects that have been observed. Indirect effects are less likely to occur, but there have been some reports of CNS effects, such as insomnia or syncope or tinnitus due to altered lipids. Again, you were reducing cholesterol, so now we're changing the levels of cholesterol in the body. Some GU effects, some altered labs, generally very rare, but have been reported. Okay, so by far, among these adverse effects, the GI effects are the most common and generally the most unpleasant. Now, in terms of some of the adverse effects, a few things have been noted. So, hyperchloremic metabolic acidosis has been observed with high doses of cholestyramine, since the drug is administered as a chloride salt. So, chloride levels, may be affected here, but generally is going to be in a situation where patient has already some predisposing condition, but it's a possibility because you're bringing chloride on board as well as the drug. Again, the musculoskeletal effects, things like backache, muscle and joint pain have been reported. Osteoporosis in older patients has been reported. But as we keep going down, irritation of the skin, of the tongue, of the perianal region, of the epithelial surfaces, these resins have been reported to be irritating. Decreased absorption of vitamins, particularly the fat-soluble vitamins, has been reported. Usually the compound is taken with 8 ounces of cold water or orange juice. has an important role in digoxin toxicity, but it is contraindicated, as we mentioned earlier, in hypertriglyceridemias, since the resins do elevate triglyceride levels. Now, another member of this class, Colesevelam, is one of the newer bile sequestering agents. It's not really new anymore, but of the three, it's the newest. It's taken as a tablet, has minimal adverse reactions. We still see some GI effects like constipation, dyspepsia, myalgia. Is not necessarily a GI effect, but muscle aches. But these are the most common side effects that have been reported. So what is the advantage of this newer drug, Colesevelam, compared to that of cholestyramine? Well, Colesevelam can be used with statins, as the cholestyramine has been shown to alter the absorption of statins. But here we don't see that to the same degree as Colesevelam. Seems to be increased compliance because of less side effects, less absorption drug interactions, and has been used successfully with things like digoxin and warfarin and the statins. However, the disadvantage is the drug is expensive, and it is less effective in cholesterol lowering than the earlier colistipol or cholestyramine. The next class of drug I'd like to discuss are the cholesterol absorption inhibitors. And really there's one major drug here that we'll talk about called the M.A.B. And so before we begin our discussion, I wanted to mention something seemingly unrelated. And that is what you see here on the left called Niemann-Pick disease. Now, Niemann-Pick disease is a genetic disorder. It's relatively rare. About 1 in 150,000 people will exhibit this phenotype. And there are several types of the disease, but the type that I'm thinking about is type C, which is a lysosomal storage disease. And the crux of the problem is that fatty molecules accumulate in lysosomes. Okay, they're not able to really move beyond the lysosome. And so this causes problems, and as you can see, all kinds of problems here in the right. If you look from birth up to adulthood, basically what you see, a lot of toxicities CNS-wise, a lot of problems with the liver, a lot of problems with the spleen, and so this is a very serious condition. And I introduce it to you because it's not really related directly to what we're talking about, but there is a receptor that is present in the body that will help with the absorption of cholesterol, and it's very similar in structure to a receptor found in this disease. And so you're going to hear me talking about a receptor called the NPCL1 receptor. So that's what we'll do in our next slide here. So the NPCL1 receptor, it stands for Niemann-Pick C1 like 1. So this is a receptor which is very similar to the one that's affected in Niemann-Pick disease. Okay? And as you can see, it's got a large extracellular region, a large intracellular region, and it spans the membrane multiple times. In fact, here we see it spans the membrane 13 times. In the lumen portion, we have a sterol binding loop that binds to cholesterol. And in the cytosolic portion, you see, we have many intracellular loops that allow the transition of cholesterol from the lumen into the cytosol. And so you might notice at the very top, in the middle portion there, we have the ezetimibe binding loop. So what is that? That's the portion of the Niemann-Pick C1-like 1 receptor, the NPC1L1 receptor, that binds to ezetimibe. And when ezetimibe binds there, what do you think happens to that proximal sterol binding function if ezetimibe inhibits the absorption of cholesterol from the lumen into the cell? Of course, right? The cholesterol is not well absorbed. It stays in the lumen. And so how does that look? Well, here we have a diagram of the localization of the NPC1L1 receptor in various places in the body. And one of the places we see this receptor, if you look to the right, is on the surface of the enterocyte, but on the luminal surface, the surface facing the lumen of the gut. And so someone ingests some food that contains cholesterol, or biliary cholesterol has been dumped into the gut lumen, as we've heard about previously. And so now one of the possibilities of that cholesterol is that it can be taken back into the enterocyte through the NPC1L1 receptor as free cholesterol, and it can be esterified into a cholesterol ester through the action of an enzyme called ACAT. Okay. The ACAT enzyme converts free cholesterol into cholesterol ester. Now, ezetimibe, by preventing that, prevents the reabsorption of cholesterol into the enterocytes. And that's significant because as ACAT makes more cholesterol esters, those cholesterol esters get dumped into the lymph and brought back to the liver here way on the left. Right? And so that that cholesterol that ends back in the liver can be liberated, can be taken into biliary canicular cells, and basically the process can repeat here. So the Niemann-Pick C1-like 1 receptor is enriched in the apical membrane of the small intestine absorptive enterocyte, where it mediates extracellular sterol transport across the brush border membrane. It is essential for intestinal sterol absorption and is the molecular target of ezetimibe, a potent cholesterol absorption inhibitor that lowers blood cholesterol in humans. And so again, if we now look at ACAT, right, up here in the upper left, ACAT is going to be used to convert cholesterol to a cholesterol ester. And so it was originally thought that ezetimibe was an ACAT inhibitor. And it was thought that disruption of the esterification of cholesterol within macrophages would have a beneficial influence on the development of arterial wall plaques. But when the activity of ezetimibe upon ACAT was studied in the lab, it was found to not be that dramatic. And it was later found to be a potent inhibitor of cholesterol absorption through the NPC1L1 receptor. So ezetimibe is depicted for you here in terms of its chemical structure. And as you can see on the right, it is offered as a tablet, so it's administered orally. It decreases the absorption of cholesterol from the diet, but also decreases total cholesterol and LDL cholesterol, as well as apoprotein B levels. It's effective even in the absence of dietary cholesterol because it inhibits reabsorption of cholesterol excreted in the bile. And again, its major target is now believed to be NPC1L1 on the enterocyte. So therefore the drug causes a decrease in hepatic cholesterol stores, and that that store of hepatic cholesterol is replaced by a reduction of plasma cholesterol as more of the LDL is brought into the liver and used for cholesterol. So this mechanism of action is complementary to the HMG reductase inhibitors, the statins, and is often used in combination with simvastatin as a combo product called Vytorin. Okay, so Vytorin is actually a combination of a statin plus this drug, ezetimibe. So what can we say about ezetimibe? Well, in terms of absorption, it's extensively conjugated to a glucuronide. Its bioavailability is sufficient for use, about 35 to 60%. So it's given orally. It's enterohepatic. It's known to undergo enterohepatic cycling. The glucuronide conjugate is 90% bound to plasma proteins. And the metabolism of the drug is primarily in the small intestine via glucuronidation, which is a phase 2 reaction. There is very minimal phase 1 oxidative reaction involved in its metabolism. Its excretion is primarily biliary, with a smaller percentage, about 11% of the administered dose being excreted renally. If we look at some of the adverse reactions associated with ezetimibe compared to placebo, we see some of the adverse effects that seem to be common for some of the other cholesterol-lowering drugs. So we see GI effects such as abdominal pain or diarrhea. Some people report back pain or joint pain. Elevated levels of sinusitis have been reported, but again, the incidence here is quite low and not that much higher in most instances than placebo. Looking at the combination of ezetimibe with statins compared to either alone, basically what you see is that in terms of adverse reactions, the highest incidence across the board are of upper respiratory tract infections, much less incidence of the other adverse effects here. Now, in terms of the combo, compared to placebo, we see slight elevation in certain adverse effects such as headache. Looking across the board, not too much. A little bit of joint pain seems to be higher in the combo than in the placebo. Okay, so generally speaking, the kinds of adverse effects you see with ezetimibe are similar for the most part to placebo, but when you see them, they tend to be things like headache or GI or muscle or joint or back pain, with a slightly increased risk of upper respiratory infection. Why that is unclear, but it may have something to do with altered effects of immune cells in the upper respiratory tract. So in terms of drug interactions, antacids have been found to decrease the circulating levels of ezetimibe, as has cholestyramine. So those will be the two that I'll mostly focus on here. Fibric acid derivatives or cyclosporine have been found to increase levels in some patients. Okay. In terms of drug-food interactions, concomitant administration with food had no effect on the extent of absorption of ezetimibe. So ezetimibe may be administered with or without food. So, kind of summarize ezetimibe, this drug can be used either as mono or as combination therapy with a statin. It may be given in monotherapy to patients who cannot take or tolerate a statin. It can be given to patients that have high LDL cholesterol, in which statins alone are not sufficient to bring those levels down. So co-administration with ezetimibe has been found to generate another 10 to 15% of lowering of LDL cholesterol. And the most frequent problem associated with ezetimibe is back pain and arthralgias. With statins, it's back pain and abdominal pain. Although you do see some bloating and dyspepsia and GI effects with ezetimibe. That brings us to niacin. Niacin is going to inhibit the release of fatty acids from fat tissue, and those fatty acids would be converted to triacylglycerides, packaged into VLDL, and eventually end up as LDL. So niacin at high dose is going to reduce levels of total cholesterol, of LDL cholesterol, and can even slightly increase HDL levels as well, as you see in the graph below. Niacin. The structure of niacin is depicted for you here in the upper right. As you can see, it looks a lot like nicotinic acid. And in fact, it was originally called nicotinic acid. But its name was changed to niacin because of confusion of nicotinic acid with nicotine, which is a toxic compound. And so niacin, we know, is a B vitamin. We know it's biosynthesized from tryptophan, that it is found in NAD and NADP as a coenzyme, which is necessary for many types of dehydrogenase reactions in the body. We know that deficiency of niacin or tryptophan can cause pellagra, which is a nutritional disease due to the lack of tryptophan or nicotinic acid. It can present with symptoms such as dermatitis or diarrhea or even mental disturbances that can be alleviated by just replacing the deficiency. And so high doses of niacin will lower triglycerides and cholesterol. VLDL and LDL are reduced, but HDLs are increased slightly. And so interestingly, while niacin, nicotinic acid, niacin, is able to do this, the related compound nicotinamide is not effective in this way. And so the mechanism of action of niacin is believed to involve the inhibition of lipolysis in fat tissue, which results in decreased free fatty acids in the plasma, decreased liver triglyceride esterification, which leads to reduced VLDL particle size, and increased lipoprotein lipase activity. Major side effects associated with niacin include GI distress and flushing, which can actually be quite severe in some patients. And so esters have been prepared, which can decrease flushing, but have not made it out to the clinic as of yet. Niacin, again, is a water-soluble B vitamin, in particular vitamin B3. Again, it's present in NAD, and it has anti-lipidemic, vasodilator, and coenzyme properties. The anti-lipidemic effects are at high doses. We're talking about grams per day, up to 6 grams per day max. And so not everybody is able to tolerate this due to some of the toxicities associated with niacin. But again, looking at its mechanism, it inhibits lipolysis in adipose tissue. It decreases liver synthesis and esterification of triglycerides. It increases the degradation of apoprotein B. And it increases lipoprotein lipase activity, which promotes the clearance of chylomicrons and VLDL and LDL. And so the result of its anti-lipidemic effects is decreased triglyceride synthesis, decreased VLDL and LDL synthesis. Other applications of niacin include peripheral vascular disease at much lower doses, or in the treatment of pellagra at much lower doses than what are used for the anti-lipid effects. Niacin is taken orally, is well absorbed, peak absorption occurring about 45 minutes after administration. The lipid-lowering effects on cholesterol and triglycerides will occur over days to weeks. Niacin is well distributed and distributes into breast milk. It is metabolized in the liver to active metabolites and excreted renally. In terms of drug interactions, aspirin may decrease clearance of niacin, and so aspirin should be used cautiously with niacin, but is used with niacin, as I'll explain in a little while. Drug interaction with statins, because of an increased risk of myopathy, increased risk of rhabdomyolysis when given with a statin. Much lower risk, of these things given only as niacin, but when given with a statin, there's an increased risk, probably due to the statin. Drug interactions with alpha-adrenergic blockers or ethanol, contributing to vasodilation, in some cases very serious vasodilation. Very rare reports of anaphylactic shock. Some reports that niacin use is associated with hyperuricemia and can precipitate gout in some patients, particularly those with gout. So the adverse effects of niacin are summarized here. In particular are the vasodilation and drop in blood pressure that can occur following administration. Sometimes that's referred to as the flushing response, facial flushing in particular. And this is due to prostaglandin release following consumption or administration of the drug. And so in order to prevent this, aspirin may be administered in higher doses, 325 mg to 650 mg, about an hour before. And that has been found to typically reduce the flushing response in patients who are prone to it. Some reports of atrial fibrillation or cardiac arrhythmias have been published, but the major effects seem to be on vasodilation and blood pressure. In terms of other toxicities, some patients will exhibit lazy eye or develop a lazy eye. It's called toxic amblyopia. They have blurred vision in one or both of the eyes. GI effects include typical nausea, vomiting, diarrhea. Maybe about 1 to 3% of the patients will develop one of those, or more than one. But exacerbation of peptic ulcer is an important adverse effect associated with niacin, and epigastric pain may be due, in fact, to the aspirin more than the niacin, but these events have been reported. In terms of hepatic events, some hepatic dysfunction has been reported, sustained or long-acting cholestasis, development of nodules, effects on the liver itself, gross morphological effects at high doses of 3 grams a day or more. Niacin has a very drying effect on the skin, so one way to deal with that is to use lanolin creams. Flushing, of course, facial flushing, you can use the long-acting form. Definitely don't take niacin after a long hot shower, which has dilated your pores. The pruritus can be treated with an antihistamine if it develops in a patient.